Again, this is the 60 Years of Newborn Screening in a Nutshell webinar with Mountain States Regional Genetics Network. We always start with honoring our funding source from HRSA. This grant is supported from the Health Resources Service Administration, and we thank them for the support of this program. Today, I'm Christy Weiss, the project's manager, and we have Sam Keith, the project's coordinator, and Jamie Stefanski, our state teams coordinator, with the green backgrounds. If you need any of us, please reach out to us. Just a couple of Zoom logistics. We are recording today. We ask that you stay on mute. You can see the active participant list, and please chat Christy or Sam if you have any technical questions or issues. As I mentioned, this is part of our Time for Genetics initiative, which is a pediatric primary care genetics education initiative in our 8-state region. We now have three full cohorts recruited with 28 clinics in our 8 states. We have completed the recruiting for cohort 3, but if you know of somebody who would like to join us and get in really quickly, please contact me through our website, or my email is there if you know a clinic that would like to participate in this free educational opportunity. We also have a library of past topics that still have CME available for them, and the topics are here. You can scan this QR code to go to our Time for Genetics library. As I mentioned, we are celebrating Public Health Genetics Week, which is done by our National Coordinating Center of the Regional Genetics Networks. This whole week, there's activities going on, this webinar being one of them. You can check out phgw.org for more information and a lineup of all the activities for this week. We do ask that you save the date. We have a genetic summit coming up in the fall, October 11th and 12th. We will have 12 CME sessions available, so we'll save the date for that. And with that, I'd like to launch into our CME statement. We are offering continuing medical education today through projects and knowledge. Today's webinar is approved for physicians, physician assistants, nurses, and pharmacists. There will be an evaluation link at the end, and this will be required in order to claim your CMEs. And the disclosures today from Dr. Matern include Neurogene Inc., member of the advisory board and up-to-date author of chapter on newborn screening and inborn errors of metabolism. And with that, it is my distinct pleasure to welcome Dr. Matern today with us. He is a clinical biochemical geneticist and director of the Biochemical Genetics Lab at Mayo Clinic, and very well known in the newborn screening community. And we are so honored to have him here today to talk about 60 years of newborn screening in a nutshell. And with that, I'm going to stop sharing and ask Dr. Matern to share his
Okay.
And I'm seeing it full screen. Perfect.
Very good. Thank you, Christy, for that very kind introduction and to the for the invitation to speak to you all, and trying to cover 60 years of newborn screening in less than 60 minutes. So let's see how this goes. So the learning objectives you probably have seen, so I don't have to go through them. I think we all understand that newborn screening is a public health program where the idea is that you identify conditions where early intervention can prevent mortality, morbidity, and disabilities. And this is traditionally, for the last 60 years, primarily performed by collecting blood on a piece of filter paper and sending that to a screening laboratory that then looks for analytes that are as specific as possible and sensitive for the condition that you're screening for. For the first 30 years, the samples were collected usually in the first week of life. And then in the 90s, the times changed and moms had to take their kids home earlier in life of the baby's life. And so the screening was moved to the second day of life. In the last 15 years, there were 2 exceptions added to newborn screening, bedside testing for hearing loss and congenital cyanotic heart disease. These are the newborn screening pioneers that got this all started. In particular, of course, Dr. Robert Guthrie, a New York Buffalo physician who was involved in cancer research and had developed assays to measure chemotherapeutics and levels in blood. And he, however, was also the father of a child with developmental delays that were never explained, never found a real diagnosis. But he was in search for a diagnosis and learned a lot about disabilities and developmental delay, and eventually attended a local presentation by a pediatrician who talked about phenylketonuria, which at that time and that was in the late 1950s, shortly after Horst Pickel, who you can see in this picture as well, a German pediatrician who did a postdoc in England and basically developed a formula that is lacking phenylalanine to see if that would help patients with phenylketonuria, where you cannot metabolize phenylalanine to tyrosine because of a deficiency of phenylalanine hydroxylase. And when that enzyme is missing, the phenylalanine accumulates in other metabolites, and they are not good for brain development and therefore cause a progressive neurologic disease. However, what Bickel then showed with colleagues in England was that a phenylalanine restricted diet can help these patients, but it could not cure them. So any disabilities that were acquired were not reversible. So Bob Guthrie, however, during that talk learned that you have to monitor the treatment by measuring phenylalanine on a regular basis. So he developed a bacterial inhibition assay that he used to, again, measure the concentration of chemotherapeutics at the time to measure levels of phenylalanine in serum. And then something else happened. He was informed by relatives here in Minnesota and Minneapolis that a niece was diagnosed with PKU. And of course, she had developed symptoms and then was eventually diagnosed with PKU, at which time she had irreversible symptoms. She was put on the diet, but she had disabilities throughout her life. So this made Dr. Guthrie think, well, wouldn't it be nice if we identified these patients much earlier before they develop symptoms, and then start the treatment early? And this was really the origin of newborn screening and of the Guthrie card. The idea to collect shortly after birth some blood from a heel stick, put it on filter paper, and then send that filter paper to a laboratory where a bacterial inhibition assay would be done to measure the phenylalanine level in the filter paper. What you can see here is an agar plate which contains Bacillus subtilis and also an inhibitor of the growth of the bacillus, which can be overcome when you have a lot of phenylalanine in your blood spot. And so all of these circles here are filter paper punches from babies with where the baby's blood. And you can see there's one here where you see some growth, and this is from a baby that has high level of phenylalanine in the filter paper. So this is an indicator that this patient has a positive newborn screen for possible phenylketonuria. So in 1962 then, Bob Guthrie was able to initiate a trial across several states where this Guthrie test was tested. John F. Kennedy was supportive of this trial and promoted it. And in 1963, Massachusetts, which was one of the states where it was trialed, actually mandated newborn screening for PKU because they found in the first year more than a dozen of patients with PKU, and it could be shown that they benefited from the early treatment. Oregon was also an early adopter and quickly added galactosemia to the newborn screening program there, so that they already had two conditions that they were screening for. And the traditional newborn screening model was very simple. You have one disease that you're interested in, such as PKU. You have one test, such as the bacterial inhibition assay. You have one marker, such as phenylalanine, and you apply a simple cutoff. And anything that is above the cutoff is abnormal and requires follow-up. Now, this sounds all very simple, but in reality is not, because the marker that is being used, phenylalanine, is not specific to classic phenylketonuria, but can also be elevated in other inborn errors of metabolism or in babies who receive total parental nutrition and get an extra load of phenylalanine through that means, but however will not be have disease. So nevertheless, from 1963, newborn screening extended to all 50 states, eventually, as you will see, and it included not only metabolic conditions such as PKU and galactosemia, but also non-metabolic disorders. The first one was congenital hypothyroidism that was added to newborn screening programs after PKU. And here you can see the implementation of newborn screening. Again, Massachusetts and Oregon and also Vermont were the first states to really start. They can celebrate 60 years this year for sure. And then other states followed relatively quickly with a few stragglers, in particular Mississippi, I think that's Mississippi, was it Alabama, in 1985, and within the mountain region, Wyoming in 1983. So they have a few more years until they can celebrate 60 years. From 1967, Massachusetts began also using urine spotted on filter paper to do paper chromatography, but they stopped that in 1991 because it really was a lot of effort and with little gain. Quebec was an outlier until today, where they continued to screening using urine on filter paper. I learned 2 weeks ago at a meeting in Canada that this program will finally come to an end, and they will only continue with the blood spots. And then in 1989 at McCabe, at the time at Baylor College in Houston, Texas, so one of your states, was the first to describe a proposal to do molecular genetic analysis as a second-tier test for sickle cell disease screening. In the 1980s, the other thing that happened was that a new group of inborn errors of metabolism affecting mitochondrial fatty acid oxidation was discovered or described. The first one was medium-chain acyl-CoA dehydrogenase deficiency, or MCAD deficiency, which we now know has an incidence in the US and of about 1 in 10,000 live births. The gene is known. There is a relatively common mutation, at least in Northern Europeans. And the classic symptoms of MCAD deficiency are that a patient who has experienced prolonged fasting or high energy demands becomes hypoglycemic and is not able to compensate for the hypoglycemia because they cannot make ketones because of the fatty acid oxidation disruption. This will cause a Rye-like syndrome with liver disease and unfortunately also sudden unexpected death in 30 to 50% of patients who are not identified before they develop their first metabolic decompensation. Treatment, however, is very easy. You just prevent fasting, and if a patient cannot have enough sufficient oral intake, you have to give IV glucose. And the diagnosis is made fairly easily by tandem mass spectrometry using an acylcarnitine profile, which was also introduced into clinical laboratories, first in biochemical genetics laboratories, in particular at Duke University in the 1980s. So here you have the story of a significant disease that can cause death in a large number of patients if it is not detected early, where the treatment is excellent as long as you identify these patients before they develop symptoms. It is also a simple treatment by avoidance of fasting, and it can be diagnosed fairly quickly by tandem mass spectrometry. And so our colleagues at Duke University in the 1990s, in particular Donald Chase and colleagues, used tandem mass spectrometry and showed that it actually is better than the Guthrie and other tests for PKU than the bacterial inhibition assay. This is a picture, an old picture from our lab, where you have 4 tandem mass spectrometry systems, and you really require only about 2 systems to screen about 120,000 samples or babies per year. So it doesn't take up a lot of room and allows you to do a lot, because you can not only measure acylcarnitines, but also amino acids, succinylacetone, which is a primary marker for tyrosinemia type 1, and then also metabolites such as creatine, creatinine, and guanidinoacetate. all in a single analysis within 2 minutes from a single 3 millimeter dried blood spot punch. So it's very efficient and effective. In a separate tandem MS method, you can measure lysosomal enzyme activities and lysophosphatidylcholines for conditions that were more recently added to newborn screening programs. And then several methods have been described and have been piloted by tandem mass spectrometry to look for cerebrotendinous xanthomatosis. Bile acids are used to look for Niemann-Pick C disease, and you can also screen for hemoglobinopathies using tandem mass spectrometry. Here is an example of an acylcarnitine profile in a patient with MCAT deficiency, where you have to trust me that this is a typical profile of acylcarnitines, where you have these medium chain acylcarnitines significantly elevated. Usually there's nothing here. And that is a picture book apparently of an MCAT patient. And down here you have an elevation of phenylalanine in a baby with phenylketonuria. So what you can see here is that these amino acid and acylcarnitine profiles are looking at multiple analytes in the same analysis. So this really introduced a new screening model where you have many conditions that you're screening for. You're using still one test such as tandem mass spectrometry. You have many markers, as the ones I mentioned, amino acid, acylcarnitines, and others. And therefore, you also could have a bunch of cutoffs, which then becomes a problem, because when you look at so many analytes, chances are that there's at least one of them abnormal or above a cutoff or below a cutoff for in every baby. So the interpretation of the analyte profiles becomes important. In 1994, molecular genetic analysis was first applied in newborn screening for CF screening, cystic fibrosis screening, as a second-tier test to reduce false positive results. And in 1996, Ed Naylor started using tandem mass spectrometry for newborn screening in a private laboratory at Neogen Screening near Pittsburgh, and really caused a lot of disruption in the newborn screening world. In 2001, you can see that some states were, such as North Carolina, using tandem mass spec at the time. They were screening for 34 conditions. And then you had others, such as North Dakota, Montana, and Utah, that were only screening for 3, and West Virginia. So people looked at this and thought, well, this is not fair. And as tandem mass spectrometry gets some traction, this discrepancy will only grow. So on the federal level, the Maternal and Child Health Bureau commissioned the American College of Medical Genetics to evaluate what's going on with newborn screening in the United States and determine which conditions every baby should be screened for in every state. And I'm highlighting here my colleague, now retired, Dr. Rinaldo, who was a significant contributor to this work. They looked at the Wilson and Youngner criteria that were developed by those authors for the World Health Organizations, looking at screening, not as in newborn screening, but in any type of screening, cancer screening or whatever, and what are the criteria that should be met to justify screening, population-wide screening for a condition. And the ACMG looked at this as well, that work group, and basically reiterated those with a few changes, primarily putting more of a focus on newborn screening and the newborn and the newborn's family. And they looked at more than 80 conditions and found a way to score each one with the input of many experts across the United States and elsewhere who were asked to kind of answer to a survey about the conditions that they were experts in. And eventually that was compiled, and this graph was created, which shows you the maximum scores for each condition, or the final scores. And they drew a line at cystic fibrosis. And so they came up with 29 primary targets, 25 secondary targets, and then several conditions that were not yet appropriate. And those here in orange have all been added to the screening panel, the recommended uniform screening panel, since 2006. Krabbe disease, which was the bottom here, has not yet been added. And I'll talk about this in a little bit. So what are primary targets and secondary targets, you may wonder? Well, if you screen for PKU, which had the third highest score, as I indicated earlier, you're also screening with when you use phenylalanine, which is currently the only marker we have for PKU screening. You also identify patients with disorders that affect biopterin metabolism. And biopterin is a cofactor of the phenylalanine hydroxylase and has multiple enzymes involved in its synthesis and recycling. And any of those enzymes may also be deficient. But it is a disease that is very difficult to treat and therefore doesn't meet at this point the criteria for inclusion as a primary target. But because it is inevitably discovered, it is considered a secondary target. So it's basically a differential diagnosis of the primary targets fall into the secondary target category. These are the original 29 core conditions: 9 organic acidemias, 5 fatty acid oxidation disorders, including MCAD, 6 amino acid disorders, including PKU, 3 hemoglobinopathies, and then 6 other conditions such as congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, hearing loss, and cystic fibrosis. And here are the secondary targets again, which are the differential diagnosis of some of the core conditions. In 2005, the Advisory Committee on Heritable Disorders in Newborns and Children, a federal committee, recommended that the ACMG panel should be adopted across the country. And in 2010, the Health and Human Services Secretary on the federal level adopted this recommendation and created the Recommended Uniform Screening Panel based on the ACMG recommendation. And this was the situation then in 2010. You can see that all states were basically screening for 29 core conditions. There were some outliers, as you can see. Illinois was already stating that they were screening for 57 conditions. And you can see in your region, it was at least 40, if not more. This is the website of the HRSA committee that I just mentioned, ACHDNC abbreviated. And I'm showing this to you because if there's a condition that you want every baby to be screened for, you can go and nominate a condition. The way that this works, once you click there, you get to a nomination form that you have to fill out. It goes to a nomination and prioritization work group of the advisory committee. And that works then with the nominators to make sure that there is sufficient information to warrant further discussion at the full committee level, where then a vote is taken, which could either lead to a rejection of the nomination, which is usually accompanied with an explanation of why it was declined so that the stakeholders can consider the gaps that may have been identified and then come back. Or it could go to an evidence review group, which currently has 9 months to review any evidence that might be out there in the published record. And after 9 months, they report back to the advisory committee, which now reviews and discusses the findings of the evidence review, takes another vote where it could be declined, or it could be made a recommendation to the secretary that the secretary should consider adding the condition to the recommended uniform screening panel, for which the secretary has 120 days to respond. If the secretary does not meet that time frame, then it is an immediate addition to the RUSP. So far, the secretary has responded, and while the secretary could decline the recommendation, so far the secretary always accepted it and added the conditions that came from the advisory committee to the recommended uniform screening panel. Here you can see that there have been people who have nominated conditions. The first one was SCID, which was added to the RUSP in its original version when the secretary adopted the RUSP in the first place. And then there are some conditions such as Pompe disease, which were initially rejected and then came back and were then added several years later. Another such condition is spinal muscular atrophy that was first proposed in 2008, was rejected, and then in 2017 came back and was added to the RUSP in 2018. Guanidinoacetate methyltransferase, another condition that went twice and was added as the most recent condition in January of this year by the Secretary to the RUSP. But then you have also conditions such as Krabbe disease, where a second nomination years later was not accepted, most recently in February of this year. So currently now you have 37 core conditions. So that list has been growing steadily. Not as fast as some people want, but apparently it is growing. I like to point out spinal muscular atrophy, which was a departure from everything else before, because here it was not just an adoption of, well, let's all screen for spinal muscular atrophy, but it was screening for spinal muscular atrophy due to homozygous deletion of exon 7 and SMN1. So there are several forms of SMA. And this exon 7 deletion is the most common form, affecting about 95% of patients with SMA, as we thought at the time. And since it is a molecular test, what the committee wanted to avoid, and I disclosed that I was a member at the time, what the committee wanted to avoid is that newborn screening becomes carrier screening and finding a lot of variants and then not knowing what to do in the follow-up. So this was the compromise, and again, was very specific. Currently, we have 26 plus secondary conditions, 26 plus because for whatever reason, the committee does not list peroxisomal disorders such as Zellweger spectrum diseases as a secondary target of screening for exorenal leukodystrophy. Not quite sure why that is, because these cases are identified. And so what I think you appreciate from the previous maps is that although there is a federal recommended uniform screening panel, it is a recommendation. And in the end, every state can do what the state wants to do. So this is a situation in 2023. And you can see the number of conditions. You have Illinois and Tennessee screening for 68 conditions. However, overall, I think it is much more uniform than it has been 20 years ago. And most kids get screened for the recommended uniform screening panel. And I think all states are working towards meeting the RUSP recommendations. However, it of course takes time to implement new tests and also new platforms to do the testing. So these are the mountain region states. Again, you have some states, Nevada and Utah, who screen already for 62, and then 45 in Arizona, although that number actually should have changed because as of, I guess, this week or this month, it should be 47 since MPS 1 and Pompe disease were just added to the Arizona panel. I also want to point out that you can still get CME when you go to the Mountain States Genetics website and listen to another talk about newborn screening in this region from last year. Also, I would like to point out that newborn screening is done by the state, but it's really the administration that's done by each state. The testing may actually be out of state. And the regionalization of newborn screening in the US is rather odd. It is not based on geography in most instances. It is based on requests for proposals and bids, and then selection of whoever. And you can see that in your region, New Mexico samples go to Oregon, Wyoming samples go to Colorado, Montana samples go to Wisconsin. And what you also would think is that by doing the regionalization, all of these programs achieve a significant amount of blood spots that they can test every year. However, if you just look at Iowa, which is screening for Iowa and 3 other states, they still have only a yearly volume of less than 70,000 babies screened, which personally, I think if you regionalize, you probably could regionalize more efficiently and effectively by having probably 10 programs in the country to screen for 3.7 million babies. So, however, we are also part of a regionalization here at the Mayo Clinic in eastern Minnesota, as we are screening Kentucky babies for a few conditions. And those are primarily lysosomal disorders, which is a new group of disorders that has been added to screening since 2006, when New York started to screen for Krabbe disease. And the current situation, just updated an hour ago by the addition of pump in MPS 1 to Arizona, you can see that there are several states that are meeting the RUSP requirements, which currently, however, includes three conditions: Pompe disease, MPS 1, and more recently MPS 2. And then there are some states that screen more, such as Illinois and Missouri and Tennessee. South Carolina just started screening for Krabbe disease yesterday. So what do we have to do with this? Well, since 2016, early 2016, we've been screening Kentucky babies for Krabbe disease, Pompe disease, and MPS 1, and then a few years later for extradural leukodystrophy, and then in the near future for MPS 2. Why is that? Because in Kentucky, a law was passed in 2015 that required that every baby be screened for Krabbe disease. And this, as laws go, they often don't come with any budget. So the screening program in Kentucky was a bit overwhelmed and reached out to us and asked whether we could help them. And we said, yes, we can help you. But we would not just want to screen for Krabbe disease, but also for the conditions that are on the RUSP, like Pompe disease at the time, and likely getting on the RUSP, MPS 1 and ALD. The Krabbe disease is a terrible condition. It's a progressive disease of which we now categorize it in 4 different phenotypes. The infantile Krabbe disease, which presents in the first 12 months of life. These patients will never walk. They're extremely irritable, develop spasticity, and then regress until they die, usually within 2 years of age. This is a baby identified and described by Knud Krabbe in Denmark in a paper in 1916. An excellent description of the infantile Krabbe disease phenotype. Then there's late infantile Krabbe disease, which is also basically as bad as infantile Krabbe disease, except that patients live a little bit longer, up to 7 years. And then there's juvenile Krabbe disease with later onset and adult onset Krabbe disease. And those patients can present with very nonspecific features such as weakness or spasticity, ataxia, vision loss, or just as neuropsychiatric disease in adults. So one has to think broadly when one sees patients and doesn't have a good explanation. It could be something like Krabbe disease. Now, there is a blood spot-based assay available looking for lysosomal disorders, including Krabbe disease, which was developed by Mike Gelb in Seattle, Washington, already in 2004. And then in 2005, this important paper about Krabbe disease was published by Maria Escolar at University of North Carolina in collaboration with John Kurtzberg at Duke University, where they could show that an early hematopoietic transplant could significantly improve survival for patients with infantile Krabbe disease who are diagnosed shortly after birth. And these are all siblings of patients who had died of Krabbe disease. So prenatal diagnosis or diagnosis shortly after birth could identify them and then allow for a transplant within the first 6 weeks of life. And again, these patients do better. So you have a screening test available and you have a treatment available, but it requires early initiation to be beneficial. And even this treatment, while it is beneficial, it is not a cure. However, the sooner you give it, the better the chances. So again, we have formed a public-private partnership with Kentucky, where we are screening for Krabbe disease, MPS 1, and Pompe disease. And ALD was added in 2018. The samples are all going to Kentucky, and then they cut out a blood spot for us, send it to us. Kentucky operates 6 days a week. We operate 7 days a week. It's an overnight incubation for the enzyme assays, and so we report on the next day, and then we return any leftover blood spots to Kentucky. What we actually do is not just a few enzyme assays, we actually do 6 lysosomal enzymes and 4 lysophosphorylcholines for ALD. We do not apply cutoffs. We have a bioinformatics system that is freely available to anyone who wants to use it, which basically looks at all these 10 results, as well as additional information such as birth weight and sex and age at collection of the baby, and basically looks for a fingerprint in these profiles, which are possibly informative for Krabbe disease, Pompe disease, MPS I, ALD, or look like a normal healthy baby. And this has been published to quite some detail. We also, when this bioinformatics tool CLEAR suggests any of these conditions we're screening for, then we do a second-tier test. What's a second-tier test? A second-tier test is a cost-effective means to reduce false positive results, in particular where you have an analyte where you have overlap with the disease range and the normal range. So basically a test that is for a marker that is very sensitive but not very specific. You do it after the primary screen, but you do it on the same specimen, no additional patient contact. And when the second-tier test is normal, then the primary screen, which was not normal, is overruled, and that's how we reduce false positives. And we have a bunch of those developed over the years. Several programs use them in-house, some sent them to other programs, including ours, again, to help reduce false positive results and reduce the anxiety that is associated with false positives. So what happens in the birthplace, samples are collected, they go to the screening lab where the primary screen is done. If it's normal, everyone is happy. If it is abnormal, we believe you should not just ask for a repeat and hope for the best, but instead go and do a second-tier test where you take, again, a punch from this original blood spot. You do the second-tier test for the specific analytes, and then that's usually normal. And if it is abnormal, you go right to confirmatory testing, which means you don't waste any time with a repeat, and you can tell the family with fair confidence that this baby actually does require intervention and is serious. For Krabbe disease, we have an analyte called cyclozine that helps us reduce false positives for Krabbe disease. For MPS I, we look at glycosaminoglycans, in particular dermatan and heparin sulfates, which also is working for MPS II and III. And for Pompe disease, we use creatine and creatinine and the enzyme activity, which can also be used for other creatine deficiency disorders and potentially for Duchenne muscular dystrophy, which has been proposed for screening as well. So this is how, again, this works. If the screen is informative for Krabbe disease and cyclozine is elevated, the screen is positive. If cyclozine is normal, screen is negative, and so forth. This is how we've been doing through February of this year. For Krabbe disease, we had done the second-tier test 116 times, so a small fraction of the babies require it. It was positive twice and actually true positive. We don't have false positives. And both of these babies have infantile Krabbe disease. For Pompe disease, we can reduce the false positives, but we cannot avoid them completely. And the same is true for MPS I, and for ALD, we didn't have a false positive yet. We had 6 patients with adrenoleukodystrophy in Kentucky and 2 with Zellweger spectrum disorder. This is the first case from Kentucky that we had. And so you can see on the second day of life, the sample was collected, went to the Kentucky lab, arrived the next day at the Mayo Clinic, which was a Saturday. On Sunday, we had results that were suggestive of Krabbe disease. So at that point, we still repeated the enzyme activity and we initiated the second-tier tests. So cyclozine, but also looking at a common severe pathogenic variant, the 30 kb deletion, which we do because Kentucky wanted us to do something molecular. On Monday morning, GALC activity was still low, cyclozine was markedly elevated, and the 30 kV lesion was not to be found. Because of the high cyclosine, we initiated follow-up. On Tuesday early morning, the patient was admitted at Duke, so out of state. And Dr. Kurtzberg initiated the confirmatory testing, spoke to the family about transplant, initiated all the investigations to find the donor and get that going if the family decides to pursue it. And on the 9th day of life, the diagnosis was confirmed by low GALC activity in leukocytes, consistently elevated cyclosine in blood spots and cerebrospinal fluid. And however, the genotype included a variant of uncertain significance, which is the reason why I think this baby would not have received a transplant on the 24th day of life if people would use genotyping as a second-tier test for Krabbe disease and, quite frankly, most other conditions. So here's our baby at 2 years old and 4 years old. You've seen the baby with infantile Krabbe disease in the original description. This is certainly different. This baby is not normal. So as I said earlier, the transplant is not a cure, but clearly this baby is a happy camper and making progress, although slowly, and we don't know when that progress will stop, if it stops. So the newest screening model, I think, is that, as I said before, we're screening for many conditions. We have multiple tests. We have many markers. And what I think is also important going forward is that you will have a bioinformatics approach to reduce false positives, reduce the number of second-tier tests that are needed, and make screening better and easier for everyone involved. It has been shown by one of my colleagues, Dr. Hall and Dr. Rinaldo, who I mentioned earlier, working with colleagues in California, where they did a look back and could show that the bioinformatics approach, which was called Region 4 Stork at the time, along with second-tier tests, could reduce false positive cases by up to 90% in California. So that is a lot of anxiety, stress, and money that is saved by doing this. So finally, almost finally, you very well know that some states screen twice routinely, by the second day of life and then again at 1 to 2 weeks old. And you know that so well because all of the mountain region states, except for Montana, screen every baby twice. Why is that? All of the gray states are wondering why. And of course, the answer is to save children. However, there's no compelling evidence that actually is true, that this is true. I've asked multiple states whether they would be willing to use the bioinformatics approach and look at least a year's worth of data where we would blinded analyze the first screen and then compare it to the second screen and see if really the second screen is necessary. My concern is, A, that if a second screen is necessary, then all the gray states should do it. But if it's not necessary, maybe you can achieve better equity, because I could not find any data that tell me whether the second screen actually reaches every baby that gets the first screen. So there might be a potential equity issue. The other question I always wonder is it fiscally responsible to screen twice without compelling evidence? Because of course you need more logistic effort to get that second specimen, to analyze the second specimen, which requires personnel, equipment, and space, where most screening programs will tell you we don't have enough money to do anything. So a lot of stuff could be done if you stop the second screen, unless it is really, really necessary. So it is only Tuesday, but on Friday, some of you may get a call from your screening labs, because what do we like to do on Friday afternoons? We like to report abnormal results on your patients. What do you do then when you get this call and it says, hey, there's an abnormal PKU test? Well, there are several things you should do and some things you should not do. You should not panic. You should also make sure that you know what actually is abnormal, because sometimes we hear about an abnormal PKU test and it's actually not the PKU test. It's an abnormal newborn screen for any of the other conditions. So you must be clear about what is actually being called presumptive positive. And then you can go to the NCCRCG or ACMG website and find act sheets and algorithms that tell you what are the next steps. So here's the NCC website, and you can here click on the ACMG and act sheets. And those were developed to help primary care providers to meet the demands of an abnormal newborn screening result that they receive at any time for all of the conditions in newborn screening. So on the one hand, there are act sheets that tell you what the analyte is, what it could mean that it's elevated or abnormal, and then what the resources are out there that can help you how to find a specialist who can advise you if necessary, and a diagnostic algorithm that tells you what are the next laboratory tests to order to confirm a diagnosis. This all started pretty much with the development of the RUSP, because the group identified a need that, well, we cannot screen for all of these disorders and then just leave the primary care providers hanging and say, hey, here's an abnormal for MCAT, deal with it. So there were also other fact sheets out there, and it was not very consistent. So it really was meant to help primary care providers. It was approved initially not only by the ACMG board, but also the American Academy of Pediatrics board. It's posted on the ACMG website and NSSGRC. It is accessible to anyone who wants it. States can adopt it or adjust it based on local needs. And this is the original group that was put together, and you can see specialists from various regions. Pointed out here is Brett Thorell, who was really the face of newborn screening in Texas for decades. And the late Stephen Goodman, unfortunately, an icon in modern areas of metabolism from Colorado. So again, these were developed to really help the primary care provider. We always asked for feedback of what could be improved, and have recently updated all of them. Also created new ones. So here's an act sheet for Krabbe disease, and we have actually two. This is for the infantile form, and this is for later onset forms. And why do we have these two? The difference is really in what is necessary. The infantile form is, you have to consider an emergency because you really want to achieve a transplant before the 30th day of life. And I always say if it can be done in Kentucky, it can be done anywhere. The later onset form, you have more time. And this is based on the cyclozine level that is achieved as a second tier test, which of the two forms are to be followed. And then there's the algorithm that tells you what are the minimum tests to determine which route this patient is going and whether it is Krabbe disease. So how does the future look for newborn screening? Well, already in 2005, Nancy Green and Ken Pass was the face of newborn screening in New York for decades, suggested, well, maybe DNA screening will be the future, and suggested that at that time. Then in 2013, the NIH wanted to explore genomic sequencing in newborns and funded several programs across the country, of which one was in California, and here's one of the papers. Here's one from the New England group, where they looked at how do the families perceive genetic sequencing for newborn screening, and those who participated and were asked were fairly positive about it, which doesn't, I believe, necessarily means all of the population, because these are consented studies. So if you consent to it, you're probably already leaning towards liking it. The Harvard or Boston group also were very happy that their approach identified a patient with non-syndromic hearing loss, with non-classic CAH, and with partial biotinidase deficiency, which were not identified with a regular newborn screen. where you could say, well, these are not necessarily the conditions that are the primary targets of screening. But of course, we don't want to miss those two, although partial biotinidase deficiency is probably not a disease. On the California side, they also did their study and they compared the tandem MS approach to whole exome sequencing. And they found that whole exome sequencing had an overall sensitivity of 88% and specificity of 98% compared to 99% and 99.8% for MSMS. So they figured whole exome alone is not sufficiently sensitive and specific to be a primary screen. And in the most recent paper from Stephen Kingsmore group in San Diego, they also changed their tune a little bit and now suggest that newborn screening, rapid whole genome sequencing is intended to supplement newborn screening, not to replace it, the current methods. So it's going to be interesting. And there are many questions that we need to ask ourselves, because who should do this? Is this something that the public health newborn screening labs are ready to catch? Should this be contracted to academic or private labs? Should there be more partnerships where the newborn screening lab does the tests, but a consultant or maybe artificial intelligence interprets the results? And what do you report? Just actionable genotypes for disease with onset in infancy only? Only actionable genotypes for diseases with onset at any age, maybe even cancer predisposition and pharmacogenomics? Any pathogenic genotype for a disease, whether it's treatable or not? Any genotype? Only the pathogenic versus variants of uncertain significance? And what platform or reagent do you use? Because exome and exome is not necessarily always the same. When I have all these asterisks here regarding external genotypes, we have to remember that the reference genome is mostly derived from white Northern Europeans. And until we have a more diverse reference genotype, we will probably not have equitable screening if we do this approach, whereas it's the biochemical approach, which doesn't care about ancestry. So what's a potentially realistic forecast for newborn screening for the next decade? I think as we go forward, and as was done for Krabbe disease, the conditions that are nominated will be more better defined, similar to SMA. And also paying attention to equity. I expect conditions could be added at 1 to 2 per year. And also if we grouped similar conditions, such as the mucopolysaccharidosis. However, I also have to admit that the current voting members on the advisory committee, including 2 from Colorado, seem to be putting the brakes on screening. I think there will be more therapies, including gene therapies, available going forward, but also that, of course, takes time and is not as fast as we all are made to believe or try to be made to believe. I think genetic and genomic testing will become more commonplace in newborn screening, but as the data suggests, it's not going to replace biochemical genetic testing. And then I also don't have any hope that there will be a more rational regionalization of newborn screening in the US, despite the advantages of achieving better efficiency and effective screening. But also remember that the RUSP does not mean that state will implement it. It also doesn't mean that if it's not on the RUSP, the states will not implement it. So that is probably not going to change either. So in summary, newborn screening is certainly one of the most successful public health programs. In the US, at least, we have mechanisms in place to expand the RUSP based on evidence, but also we have to be honest that some evidence doesn't emerge until you actually do the screening. The most efficient and effective approach to screening relies primarily on biogenetic testing for first and second tier tests. At this point, molecular genetic testing and genomics for newborn screening is of limited value given the high cost, the time it takes to complete the analysis, and the frequency of genotypes of uncertain significance. And I think the biggest limitation to expansion of newborn screening is not laboratory testing and result interpretation, but the lack of treatment options for very rare conditions. And with that, I would like to end with being grateful to everyone in the lab here at the Mayo Clinic, all of my colleagues, our colleagues in Kentucky who allow us to screen the Kentucky babies for these conditions, and Megan Lyon, the co-project director of the National Cohorting Center. And with that, I'm done and take any questions.
Thank you so very much. That was a great presentation. We do have a couple of questions and comments in the chat. So if you don't mind stopping sharing, I'll go ahead and share over you, if that's okay, just because I want to let everybody know we're also putting the evaluation link in the chat so that everyone can fill that out. But we did have a couple questions come through. There was a question from one of our Utah newborn screening colleagues about Utah screening for 42 disorders. And so could you maybe just speak to the counts? Sometimes there's differences between certain maps that we might look at with the counts and why that might be.
Yeah, so it takes a long time to go state by state. So I take the shortcut and go to either the APHL website, the new steps, or to Baby's First Test. The problem is that they're not always updated as states add conditions. So for example, Arizona, I looked up this morning because I had heard somewhere that it might start in May. And however, at the APHL website, that's not reflected there yet. So yes, that's why I reference where I have my information from, so that you cannot blame me.
Yeah, thank you. I appreciate you clarifying that. We also have a question from one of our Time for Genetics clinicians that's participating. She says, I have been told that the first screen is done in the hospital because of lack of regular follow-up pediatric care in Las Vegas, but that the 2-week one is more accurate. So the ones that do get to the follow-up are able to eliminate those false positives. Are you saying that 1 to 2 day one is all just as accurate due to the ability to do the second test with the original sample?
Yeah, so there are two things here. The second tier test is for conditions where you have a better analyte that you can test for. So that could be possible. Now, some of the second tier tests, these are time critical conditions. So that's the other problem I have with just waiting for the second one, which I don't think the states do. If it's really a very abnormal result, they will report it and it will be identified. When I'm saying that there's not compelling evidence to support the second routine screen, it is because I cannot find it. What usually happens is that you compare the positive results or the true positives in a state that does a single screen versus a state that does 2 screens, but it's, yeah. And that's what I've been asking to do, is that they give us, or they can do it too, because CLEAR can be used anywhere. They use it to throw in the de-identified data of the babies at 2 days old, and then the same babies at 2 weeks old, and then see whether you really identify more cases with the second screen. Because right now they apply different cutoffs at the different time frames. And for some of them, in particular, congenital hypothyroidism is always mentioned. They let go of more cases with the second screen because they know with the first screen, because with the second screen, they don't have to worry about prematurity that much, and therefore get presumably more accurate results. But again, I would love to do the test because I think if it is really necessary, we all should do it.
Great, thank you for answering that. And I think this is a colleague from the CERN region asking, did Kentucky Medicaid or health insurance pay for that bone marrow transplant that you referenced, I believe, in the Krabbe case?
Good question. Somebody paid for it.
No worries. You're
I don't know.
Not sure. Okay, that's okay. And then one last question. We're just with 1 minute left here on our webinar slot. Would you please comment on congenital CMV, especially since Minnesota began universal screening this year?
Yeah, so yeah, so this has been started here. And I don't have any outcome data at this point. We have an advisory committee meeting, I think in June, where we probably get some first data. As far as I know, the test that is being used is not the best test. So at this point, I would not advise anyone to start until there are more data out there. Let's put it that way.
Great, thank you for that. And I just have a couple more slides that I just wanted to wrap up with. I'm just going to ask Sam if she can put again the evaluation link for anyone who missed that. And just remind everybody that our next Time for Genetics webinar will be in September. We'll be moving on from newborn screening as our topic area to seizures and genetics. So keep an eye out for that. And just please save the date for our genetics summit that will be virtual coming up in October. With that, here's my contact information. Dr. Matern also had his email on his slides that we'll be sharing later. So if he's open for additional questions that might not have been answered here today. And then we just wanted to please join me in thanking him for this great presentation. And thank you all for your time today to join us here at Mountain States Regional Genetics Network for this webinar. Thanks, everyone. Bye-bye.
Thank you.